So I'll spend a couple of words which really link to what Rick just mentioned about the role and the value of phantoms in chest CT. Because we can be sure that people who start screening now at age 50, they will not have the same CT scanner in 30 years that they will have for their CT screening. Probably already within 5 to 10 years, there will be a trend towards much more availability of photon counting CT. So we have loads of different variations that we could envision already now that relate either to the scan protocol or to the reconstruction. And with relation to reconstruction, you can do a lot of work even with existing data, with participant scans, but we cannot continuously add acquisitions to standardize and validate new protocols using screenees because of the radiation dose. And that's where phantoms come in. So the pros are you can just keep on scanning, you can twist them around a little bit, you can use different scanners, you have an unlimited choice of CAM protocols, but you also have a ground truth for your biomarkers. And that makes it very, very good techniques for standardization of and validation of new scan protocols. And you can use some sort of diverse patient size. But we have to be aware that it's a simplification of the human situation. So they're not directly generalizable to the screenee cohort. In our institution, we have a head physicist, Dr. Marcel Greuter, who is very keen on the chest CT phantoms. So in the past years, we have done a lot of different, we have scanned a lot of different phantoms. This is a well-known phantom for lung nodules, the lung man, which is basically a humanoid phantom that includes an insert for the heart and pulmonary vessels. It has no lung. So what you see here on the right side is pure air. And you can stick all kinds of nodules, as you see nodules with that are round or spiculated or lobulated with known size and density into that phantom. And so, for example, we recently checked the accuracy of new photon counting CT protocols and see how far we can reduce the dose towards an X-ray level and still find very small nodules. For calcium score, and I think this is important, when we consider comprehensive screening, which we'll be discussing tomorrow, you also have to be aware that any change you make to your lung screening protocol will possibly affect your calcium score. We have, however, multiple phantoms that can be used to at least get an idea of the impact, which is this round insert with 135 millimeter diameter calcium spots, but also tiny calcification phantom, as you see on the right. You can have body habitus inserts to make the diameter larger. And we also have a calcium finger that moves with different frequencies that you can adjust, which simulates heart rate. For example, we found that ultra low dose imaging with thin filter actually reduces your calcium score. Now, for emphysema, we currently lack an anthropomorphic phantom. So we do have some simplistic methods like this one. We recently tried to make something more humanoid. We use an actual CT scan to do a 3D print that has not only vessels, but also bronchi. And we used cork to simulate more like lung parenchyma-like tissue. So this may be helpful for validation of emphysema situations.
Thank you.